So today we'll
Oh,
be talking on a bispecific CAR T, which targets both anti-CD20 as well as anti-CD19, and this was studied in relapsed refractory mantle cell lymphoma, and this was published in JCO in 2025. So, since we are studying on or doing JC on CAR T cell therapy, we did IL-18 armored anti-CD19, then CAR T cell therapy in ITP, and allogeneic CAR in LBL, and now we are uh, going for anti-CD19 20 bispecific CAR. So mantle cell lymphoma is it comes under both the indolent slash aggressive B cell lymphoma, and it has trans characteristic translocation 11-14 and has a bright CD20 expression. And the clinical course is relapsing, remitting, and it is almost incurable without a transplant. So current therapies are available, which include chemoimmunotherapy, BTK inhibitors, and also CD19 CAR T cell therapy. But all these therapies are met with limitations such as high relapse rates, toxicity, as well as antigen escape, because the amount of CD19 expressed by these cells is relatively lesser than CD20 expression. So these cells are this tumor is more susceptible to antigen escape, and it has higher relapse rates with CD19 for the same reason. So in this study, they made dual targets. So mantle cells express both CD20 as well as CD19, and the CD20 expression is higher than CD19. And CD19 only CAR T has risk of antigen escape and limited durability, as we said. And the study hypothesized that dual targeting will improve the outcome. So the study objectives was it was a phase 1/2 trial, and the primary objective was to ascertain the safety of our dose limiting toxicities and to look for the manufacturing feasibility. And because they used interleukin 7 and interleukin 15 instead of interleukin 2 in this, I'll be talking in detail about that. And in phase 2, the primary objective was to see 90 CR rate, and the secondary objectives were overall response rate, progression-free survival, overall survival, MRD status, and also they studied cellular kinetics and cytokine profiling. So, phase one was a safety trial with 3 patients, and phase two was for efficacy with 14 patients. And they used they used lymphodepletion with fludarabine cyclophosphamide, uh, and a CAR T dose which was given was 2.5 into 10 to the power 6 cells per kilogram. So the manufacturing process is in a diagram. So they did leukapheresis on day -1, and they selected T cells and they activated to make them express CD28 on day 0. And they transduced on day 1, and they expanded it on day 3, and day 7 they checked the process and QC, and then on day 8 and day 12 they harvested. So instead of using interleukin 2 for expansion, they used interleukin 7 and interleukin 15. So the patient population was a relapsed refractory mantle cell lymphoma, which who underwent more than 2 prior lines of therapy, and 94% of the study population were proton tyrosine kinase exposed, inhibitor exposed. So, and also around half of the patients had TP53 aberrations, and 18% had percentage had complex cytogenetics. And the median prior lines of therapy received for these patients were 4 per patient. So this is in short, the demographics. The median age was 63, and 8 patients had out of 17, 8 patients had underwent autologous stem cell transplant before, and 2 had underwent allogenic stem cell transplant. And more than and around 94%, 16 out of 17 patients were Bruton tyrosine kinase inhibitor exposed. So the manufacturing process, this is a tandem bispecific lentiviral vector. Which targets both CD20 and CD19. So if we see in the diagram, there is a domain for CD20 binding and a domain for CD19 binding with a CD18H and 41BB as a co-stimulated domain. And there is a CD3 cytoplasmic tail for signaling. So, and they used 8 to 12 day process. So I'll be coming back to that. and they used interleukin 7/15. And in 82% of the patients, they infused the fresh product rather than the cryopreserved product. They didn't use cryopreservation in most of the patients. So, and also they studied the comparison of expansion with interleukin 7/15 versus interleukin. So the efficacy, the best overall response rate, the best overall response rate was 100% with a CR rate of 88%, and the day 90 CR was 86%, which was the primary endpoint in the phase 2. And there were 2 out of 17 relapses, one at 8 months and one at 24 months, which I'll be telling about in later. And median PFS and OS were not reached. So the 1 year progression-free survival was 80%, and the 1 year overall survival was 86%. Actually, the study had a median follow-up time of 15.6 months. So they had done 1 year PFS and 1 year OS. So these are the efficacy response rates. The best overall response rate was 100% with 88% having CR and 12% having PR. So if we see in the swimmers plot on the right side, so the plots with the red dot are the ones which had relapsed. So 2 patients had relapsed. And if we see both these patients, they have a red inverted triangle on their path. So they are meaning to say that those patients were MRD positive. So the 2 patients who relapsed, both were MRD positive. So this was the PFS and OS which we talked about. And regarding MRD outcomes, which was also studied, so at day 28, 80% were MRD negative, 12 out of 15, and at day 90, 79% were MRD negative. And relapse occurred in only 2 patients who were MRD positive. And all MRD negative patients, who were MRD, sorry, am I audible?
Yes, sir, yes, you are audible.
So all the patients who were MRD negative at day 28, they continued to stay MRD negative till day 9. So regarding the 2 patients who relapsed, so 1 patient who relapsed at 88 months and another at 24 months. The first patient who relapsed at 8 months, he had CD19 dim when they checked, and the CD20 was negative. Actually, the patient was CD negative even before they started the CD20 negative even before they started the therapy. So, despite having high number of circulating CAR T cells, which is around 15% of all CD3 positive cells, he relapsed because CD19 was dim and CD20 was negative. And the second patient who relapsed, he was both CD19 and 20 positive, but the CAR T levels were undetectable. But, the study hasn't mentioned at which time point it was undetectable, but they have mentioned it was undetectable. So, regarding CAR T expansion and persistence, so the CAR T levels were detectable from day 4, and the peak expansion was from day 7 to day 14. So, in some patients, it was persisting more than 1 year. And they also noticed that patients who had higher B cells pre-infusion, they had a greater expansion. And this is attributing possibly to the T cells being stimulated by the presence of B cells and that leading to greater expansion. So this is the graph showing CAR T expansion and persistence. So if we see the graph at around first week to the second week, there was the highest peak, the green lines. And this is based on the number of circulating B cells. So if the circulating B cells, the black lines, if they are more, the expansion of the CAR T product was more. So they have made a complete profile of one of the patient they had given. So at day 7, the total number of nucleated cells that were CAR plus was 9% in blood. And around as the time passed, around 2 years, it had gone closer to 0.01. And they also measured at the end of 2.5 years in CSF, it showed presence of no CAR T cells. Regarding safety, CRS occurred in almost all of the patients, 94% of the patients, but all were grade 1 to 2, and it occurred at the median of 1 day, first day. And ICANS occurred in 18%, and 2 patients had grade 3 ICANS, and they were managed with intrathecal steroids and intrathecal triple therapy. They gave high, and There were two cases of non-ICANS neurotoxicity, and it presented late and atypical and at day 41 and day 58. And the study mentions they were treated with intrathecal steroids, and the patients resolved completely. And there were no need for shifting to the ICU within the 28 days. And regarding the study also assessed the level of interleukins in the CSF before and after giving the IT therapy. So before giving the IT therapy, this is the baseline levels at the left. The CAR T cells and the interleukin levels. If you see the first diagram, for example, the interleukin 10 levels were high, and once the patient was given intrathecal triple therapy, then the interleukin levels came down. So in all of the interleukin levels came down, and the study says that the patients responded well to intrathecal therapy when there is ICANS or neurotoxic ICANS like neurotoxicity syndrome. And the study also assesses the presence of hemophagocytic syndrome, HECHS, and two patients had them. And both these two patients had hyperferritinemia. The study says more than 20,000. And the study also reports 5 out of 17 treatment-related mortalities. Sorry, the first one is not in arrow. The treatment-related mortalities. There were two relapses, and there were three reinfections. So all the three infections occurred during the period of B-cell aplasia. So one was GNB sepsis, one was meningoencephalitis, and one was due to COVID-19. And regarding hematological toxicity, there was grade 3 neutropenia, which was the predominant one, and there was anemia and thrombocytopenia with it. And 65% of the patients had hypogammaglobulinemia, and they received IVIG. So regarding immune reconstitution, B cell recovery was variable, and in some of the patients there was still B cell aplasia and during their median follow-up time of 15.6 months. And at day 90, almost all of the patients had low IgG levels, median of 398, and they used IVIG supplementation for everyone almost. So this diagram shows the presence of CD19 cell count post-CAR T. So if we see only uh, above the 400 mark, only two patients have reached the level at the time of follow-up. Other patients had low persistent low B cell and hypogamma globulinemia. And when they assessed the manufacturing feasibility, so all patients had successful manufacturing, and their target dose was 2.5 million cells per kg, and they could achieve that in all 17 patients. And 14 patients received fresh products but without cryopreservation, and they compared both the process 8-day manufacturing versus 12-day manufacturing. So for 13 patients, they used 8-day manufacturing. The expansion time was shorter. This and 12-day manufacturing, they used 4 patients. And there were no statistically significant change in CD4 CD8 ratio or naive stem cell like T cells in both CD4 and CD8 subgroups. And also they did single cell cytokine analysis. So all these cells were able to secrete cytokines similarly. There was no difference between 8-day manufacturing as well as 12-day manufacturing. So and they used this time interleukin 7 instead of interleukin 15. So they compared this product with the same similar product which in a previous trial the same group study where they used interleukin 2 for expansion instead of this. So they found that in compared to interleukin 2, interleukin 7/15 had more CD3 expansion and more transduction efficiency, and there were more number of naive or stem cell like uh, CD8 T cells, and also the interleukin secretion, which is by single cell analysis, so which is called as polyfunctional strength and index PSI, was improved in interleukin 7/15 compared to interleukin 2. So if we see the right diagram, when they used interleukin 2, the percentage of CAR T cells that transducted was close around 18 percentage. In compared to interleukin 7, it was around 25 to 26 percentage. Also, if we see the T cell expansion with interleukin 2, the red bars, so they are relatively on the lower side compared to the blue bars, which used interleukin blue lines, which used interleukin 7 or interleukin 15. So, and apart from that, they had surplus cells from two patients with which they manufactured a product which targeted only CD19 instead of CD19 and 20. So, after manufacturing this, they tried in a Bruker beacon platform for assessing the cytotoxicity of these cells. So, this bispecific or 20 and 19 targeting cells showed more rapid and robust cytotoxicity. So, they had divided the cells into three different categories based on how fast they are killing the cells. So they are called slow killers, which take around 24 hours to kill, and then the medium killing cells 8 to 16 hours, and less than 8 hours is fast killing cells. So when they used bispecific 20 and 19 targeted cells, there were more fast and medium rate killers uh, compared to only CD19 targeted cells. So the key advances and strengths of the study, dual targeting eliminated antigen escape, the possibility of antigen escape, and rapid manufacturing was feasible, 8-day process, and many patients could receive a fresh infusion without cryopreservation. And there was shorter vein-to-vein time, so they avoided bridging therapy also. And there were no more than grade 3 CRS and manageable ICANS. And also the study demonstrated with the use of intrathecal steroids, the cytokines in the CNS can be modulated without the risk of CAR T engraftment. And they also assessed hemophagocytic syndrome as a new safety signal in this study. And also it was MRD driven, so, and 100% PF is in patients who were MRD negative by day 90. The limitations were single center and small sample size. And the follow-up was rather short with 15.8 months. And there was a high mortality, 5 out of 17. And also 3 out of them, NRM was 3 out of 17, and it is due to infections during the prolonged B-cell aplasia. So the clinical implications, this might be a potential new standard for relapsed refractory mantle cell lymphoma. And with the shorter vein-to-vein time and shorter manufacturing time, yeah, skipping bridging therapy is feasible. And it also says that all these patients which we are treating with single target or dual target CAR T cells, which target B cells, prophylactic IVIG is recommended. So when they compare this with the previous CAR T, so it is not a fair comparison because this targeted two antigens, whereas Brexucell and Liso-cell targeted only one antigen. So overall response rate was 100% with CR rate of 88%, and the CRS and ICANS were relatively less compared to other two trials. And the median progression-free survival was not reached. So the study suggests multicentric trial, longer follow-up, and MRD-guided consolidation as future directions. So to take home, and bispecific CAR T with CD20 and CD19 is highly effective in relapsed refractory mantle cell lymphoma with a good safety profile. And MRD negativity predicts durable response, and it may change practice confirmed in larger trials.